The reason why I think that the rigid regulation doesn't work is because a doctor is not a doctor is not a doctor, a nurse is not a nurse is not a nurse, a therapist is not a therapist is not a therapist, and an individual is not an individual is not an individual. So we can't keep treating everybody like they are identical, and that you can deal with them all in the same way, and that you can tie a standard to this that fits everybody. So I'll give you an example. In Lethbridge, about 8 or 10 years ago, they were faced with a severe shortage of what you would call complex continuing care beds. They're called extended care beds in Western Canada. And they just had a very big wait list for people, and they had no more facilities, and there wasn't any prospect of having any time soon. And these people were getting an average in complex continuing care, I believe, 2.5 to 3 hours of nursing, professional nursing care a day. So they didn't have any choice. They had to put these people in what were essentially assisted living facilities, very light level care places, because those were the only beds available. And then they followed them up, the people who got admitted there who were absolutely fully assessed complex continuing care clients. And these people, when they went into assisted living, obviously got way less care, and they got way less professional care. Well, lo and behold, after 2 years, more people went home alive from the assisted living places from a complex continuing care assessment than from the complex continuing care facilities. They actually had better outcomes by being what many people were yelling about was a severe underservice. So then they did a study. They went into a complex continuing care facility, the large one, and said, let's do a chart-based review to see, based on their conditions and how these people were doing, how many times a month they actually needed professional nursing care, RN level care. And the answer was an average of once or twice a month. Not 3 hours a day, but once or twice a month, because these people, while seriously compromised health-wise, were pretty stable, and their conditions could be looked after very well by people who were not RNs. Well, this, of course, was a very controversial finding and so on, but it's an example of how ingenuity responds to a problem, and you find things that you never would have found if you weren't looking, or if you didn't have to look. And I think that's true all through healthcare. If you look at primary health care, we've had about 40 studies worldwide, randomized controlled trials that show that nurse practitioners can participate very, very centrally in primary health care. And we've been very slow to maximize their impact on the system in Canada, even though we have a shortage of family physicians, and we have now a growing number of nurse practitioners who are by and large frustrated because they can't practice to the maximum scope of practice. Why does this happen is my question. What do we need to do in order to make their work life better? And frankly, it will make physicians' work life better too, because as you can see, physicians are not very happy these days. They're not happy with their hours of work, they're not very happy with their scope of practice, and frankly, in the ones I've talked to, a lot of them after 20 years are pretty damn bored, because they're doing too much routine work and they are not using the high cognitive and educational skills for which they were trained. So that's what I mean by liberating the workforce and liberating the workplace. I don't believe people in healthcare are inherently crazy risk takers. There's not going to be any evil Knievel medicine out there if you say we're going to lighten up on the regulation a little bit. People will be cautious, but they may get a little more creative about what they do. And everybody who has gone to a collaborative practice mode, everyone who has rearranged the division of labor, everyone who has devolved a seemingly complex task to someone who previously was not deemed suitable to do it, has said that was a brilliant idea. And remember, Ontario was starting to lead the way in some of this. You're getting nurse endoscopy and nurse anesthesia. It's a brilliant idea. I mean, in India, people with 6 weeks of training are doing wonderful outcome cataract procedures. So I think we have to do a major rethink on what constitutes an adequate training level to do certain things and who should do what. And it may be that certain categories of people, certain people with 15 years of experience may have a vastly different inclination to do things than an identical person who graduated at the same time but who is less inclined to expand the scope of practice. I think we need to adapt to what individuals want, and teams will redeploy themselves in different ways based on the characteristics of the team members. We need to get out of the way of them doing that.